Hi everyone, I'll get started here in just a minute. All right. So, hi everyone, my name is Dr. Aylah Clark, and I am a naturopathic doctor practicing at Whole Health Wellness Center in Avon. And tonight I'm going to be telling you about lipedema. And before I get rolling, I do want to mention that if by chance you are new to our office and are considering being a patient, there will be an opportunity at the end to sign up for a free 15-minute consultation with a member of our team. And that can be a great opportunity to answer questions about insurance coverage or what to expect and things like that. Without further ado, I'll get started. So I'm going to be telling you about what lipedema is, the diagnosis, how it's made, the types and stages of lipedema, and then I'll be going through the pathophysiology, basically how does this happen, why does this happen, and what do we know to date, and then a whole bunch of different treatments. So lipedema is a fat disorder that almost exclusively affects women, and it's characterized largely by the painful fat that primarily affects the lower limbs and sometimes arms. There's not a specific test to diagnose lipedema, except unless we're doing some testing to rule out other conditions. There may be some imaging or labs done for that purpose, but most of the diagnosis is made clinically, and this will help explain some of the other symptoms people might experience with lipedema. The original criteria has been published since 1951, and that is that lipedema almost exclusively occurs in women with the onset within the third decade of life. The exception to that is that sometimes menopause can trigger lipedema. It tends to happen bilaterally and symmetrically, often with a bracelet appearance at the wrist or ankles. That's not true for everybody because not everybody has their entire leg or arm affected, and it might not have that braceleting cupping appearance. But for many people it does. There's minimal pitting edema, and what that means is if somebody were to press in with their thumb on your shin or in the area that's affected, that for several seconds and let go, the indentation typically doesn't stay. It doesn't stay pitted, but it can happen somewhat or in other conditions that can overlap. It's characterized by pain and tenderness, and it also stays enlarged. The area that's affected stays enlarged even when it's elevated. So in conditions like lymphedema, you might see a change in the size of the area if you elevate your legs, but that doesn't happen with lipedema. Vascular fragility is really common, and that gets translated to easy bruising as the symptom people experience. In 2016, some additions were recommended because there were a few things that weren't quite covered by those original criteria, including the arms being affected 30% of the time, coolness of the skin, and some others, especially the unaffected by caloric restriction piece, is very important. That's one of the characteristics that people really notice when they feel like something's wrong, where you've done different dietary changes and you've done exercise and it's just not making a difference with the fat in your legs. And then spider veins are another one. Prevalence, this has kind of changed over time, not the prevalence itself, but just what we thought was the prevalence. Previously, it was occasionally thought to be a rare condition, and then at some point, we saw about 1 in 72,000 was an estimate, but now it's generally accepted that as many as 10 to 11% of women may be affected. There are different types of lipedema, and this really just means what parts of your limbs, your legs especially, are affected. So sometimes it's only the buttocks, sometimes it goes down to the hips and the thighs being affected, and it could be the entire limb length, and sometimes the arms are affected, as I mentioned before. And so these are the types that you can sometimes see, and very rarely you can see only the arms being affected. These are the stages of lipedema. So in the stages, we see in stage 1, typically there's very little change to the texture of the skin. You don't see those outpouchings that you do later on. You can see lymphedema in earlier stages, but it's also more likely to happen in later stages. I'm going to talk about some of the overlapping conditions with lipedema because these are the main things you're often trying to exclude from the diagnosis is lymphedema or lifestyle-induced obesity causing the symptoms, or does somebody have a combination of the 3 or 2 of the conditions? Lipedema and lymphedema coexist frequently. It's very common for people to have both, but you can see a difference in these conditions as well. And some people have lipedema and don't have lymphedema. So it's worth looking at the differences. One of the main ones is that lymphedema involves the feet, whereas lipedema does not. As I mentioned earlier, lymphedema does tend to change a little bit with elevation when you elevate your feet. And it can be asymmetric, more so than lipedema, where in lymphedema, you are more likely to see one limb that is of a greater size than the other. Lipedema versus obesity, this is another one where they overlap quite a bit. As many as 50% of patients with lipedema also are overweight or obese due to lifestyle factors. And the main difference here, however, between these 2 conditions is that when you lose weight with obesity, it tends to come off more uniformly, whereas with the lipedema, it does not tend to come off from the legs. And as I mentioned earlier too, lipedema is almost exclusively in women. So if a man does come in, perhaps wondering if he has lipedema, it's much less likely. Okay, so I'm going to talk about the pathophysiology of lipedema. And so this is our understanding so far as to what some of the contributors to the condition are and why it happens. We know that there are some genetic influencers. Epigenetics, maybe. We don't have a lot of, or any research to my knowledge on that, but that is a common reason for changes to happen later in life, like we see in lipedema. We know that estrogen receptor expression is different in people with lipedema than people who do not have lipedema. And I'll go into that some more as well. There is inflammation as well as vascular and lymphatic impairment. So I'm going to go through all these in a little bit more detail. As far as the genetics go, some studies show that about 60% of people identify a first-degree relative with lipedema. And this is a little bit tricky because, as many of you may know, if you have lipedema, or maybe if you're hearing about it for the first time, previous generations were not being diagnosed with lipedema because we didn't know about it, or not enough people knew about it. So a lot of this is people identifying their family members and saying, yeah, my mom had the same legs I do, and that kind of thing. So as we gain more awareness, we'll get a better idea about this and the genetic predisposition. We do think it happens through an autosomal dominant inheritance pattern with incomplete penetrance. It's not really important for you to know necessarily, but that is the pattern we seem to see. There's a lot of information on this slide about the estrogen receptor piece, and I'm going to try to keep it fairly simple, but I apologize if I get in the weeds a little bit. But the reason why we started investigating estrogen receptors initially is because we noticed it primarily affects females, and it also tends to appear after a hormonal shift like puberty, pregnancy, or menopause. And so furthermore, we know that estrogen also affects the distribution of body fat. Hormones like leptin that affect body fat and insulin sensitivity, inflammation, and pain, all things that are affected with lipedema. And our research in the past few years indicates that people with lipedema may have decreased estrogen receptor alpha expression and increased estrogen receptor beta expression in the gluteal region as compared to the abdomen. And these end up translating into some of those symptoms that we see in lipedema. So estrogen alpha is usually seen as pretty protective and especially important for the lymphatic vasculature. It needs that signal to help protect from lymphedema. We know from other studies that blocking this receptor, estrogen receptor alpha, with drugs like tamoxifen will impair lymphatic function. And so it's not surprising that if we see decreased expression of estrogen receptor alpha, that we could see impairment of the lymphatic system ultimately. And we also have seen studies where blocking estrogen receptor alpha in the brain can lead to metabolic syndrome. Estrogen receptor beta is a little bit different. And so with an increase in expression of that receptor, we could see impairment of insulin and glucose metabolism. So I know that has a lot of science on there. The big picture is just that we see differences in the expression and distribution of estrogen receptors in lipedema, and ultimately that might lead to treatments down the road. So lipedema fat actually does look different than normal fat under a microscope. And as you can see in these pictures, there's more size variation of the fat cells in lipedema. There's also that thicker septa or line around the fat cells and more debris between the cells than in the normal fat cells. Keep this picture in mind as we go through some of the next slides because it'll make more sense. And I know this has a lot on it too, so I'm going to walk you through this. This slide is a flow chart representing some of the hypotheses we have on how lipedema happens. And this is an evolving thing. So we're going to start on the upper left and we're going to end on the right. The right, we have these symptoms and signs that we see in lipedema, like the bruising and lymphedema and pain and reduced mobility and arthritis. So looking back up to the left there with the polygenetic influencers, we talked about that. Those are genes that somehow influence the development of this condition. We know that these hormonal shifts are triggering a change, and we have a difference in the expression of that estrogen receptor. And these things we know lead to the increased number of size and number of fat cells in the legs. And this can lead to fibrosis, like a thickening. We see an increase in the release of free fatty acids, which both can contribute to inflammation. And we see an increase in limb size, of course. Moving down along the bottom here, that increase in limb size, of course, if you've experienced this, you know that that can lead to pain and arthritis and reduced mobility. And we think that happens possibly because of this neurogenic inflammation, which means inflammation of the nerves and compression. moving back up to that fibrosis and free fatty acids, those cause more inflammation and capillary fragility there. With the capillary fragility, we end up seeing less blood flow into the area. And that's where this hypoxia word comes from. So moving up there, when cells aren't getting enough oxygen, they die. And so we see that happening here. When fat cells die, we get these immune cells called macrophages that come in. These are like Pac-Man cells that come in and try to clear up debris. But in some cases, they can actually lead to more inflammation, especially if they can't get out of the area. So they can sometimes just end up contributing to the problem. So moving more to the right here, we get more vascular and lymphatic hyperpermeability, which means that more fluid is leaking out, and we could see lymphedema, we could see bruising and hematomas and petechiae. And we also see that on the microvascular level, these things can build up and end up affecting on the macro scale. So you can actually see larger vessels being affected. And there are studies that have shown that people with lipedema are more likely to have aortic stiffness. So something to keep in mind for the long term in thinking about cardiovascular health. I'm going to go into how we might address some of these along the treatment slides coming up. So I know that's a lot of information, and it's an evolving bit of information too as we learn more. There are a number of conditions that seem to occur more frequently in patients with lipedema. I mentioned the orthopedic problems and arthritis already, but there are some others. Chronic venous insufficiency can happen, and fibromyalgia seems to happen at a higher rate. Some of this might be people being misdiagnosed with lipedema, or rather fibromyalgia, when they really had lipedema that may have been diagnosed later. But there may also just be a higher incidence of fibromyalgia as well. And hormonal imbalance, hypothyroidism. Hypothyroidism is also at a higher rate in lipedema, it appears. Different from what some of the literature used to say about lipedema, more recent studies seem to indicate that lipedema is not necessarily associated with an increased risk of some of the metabolic conditions like hyperlipidemia, which is high cholesterol, high blood pressure, prediabetes, and things like that. These conditions are still super common. And so if you do have these and lipedema, it is certainly still something that should be addressed and may exacerbate the condition, but not necessarily. A lot of people with lipedema do not have these issues. All right, so I'm going to go through a number of treatments here. It's a complex condition. There's a lot of different aspects to it that we're learning about, as you've seen, with the inflammation and the lymphatics, the hormones. And so there's a lot that we can address here with different treatments. The initial goals are to help prevent any progression and improve the quality of life. But there's more we can do than this. It's also setting expectations, though, because there's no known cure at this time. Some treatments can make this significantly better. And it is generally seen as a lifelong condition. So moving forward, as a naturopathic doctor, I am always aiming to try to treat the whole person. And some of my goals are addressing the foundations of health, treating the root causes of conditions, and making sure we're treating other comorbidities, meaning other conditions that might be impacting the primary condition we're trying to treat. I'm going to go through each one of these. And in general, the way this whole treatment section is set up is really from of the foundation up. So we're going to end on some of the more intensive treatments, but we're going to start with some that are more basic. So starting with the foundations, I'm going to talk a little bit about sleep, nutrition, exercise, and mental health. All right, so I talk about all these foundations with most of my patients because they really do impact just about everything. Insufficient sleep can decrease your metabolic rate enough to translate to a 12.5 pound of weight gain per year, according to a 2017 study. And if you have lipedema, you don't need that added challenge. If you have sleep apnea, in addition to lipedema, which can also increase inflammation and make it harder to lose weight, you don't need that added challenge. So this is something I'm going to work on, whether it's trying to identify any undiagnosed sleep apnea or if it's just trying to optimize somebody's sleep, that I think it's an important foundation to work on. So as far as nutrition goes, I could do an entire talk on nutrition by itself. So I'm going to have to cram a lot of information into this one slide as best as I can. So as we mentioned before, caloric restriction is not the best treatment for lipedema. In fact, it can be harmful in feeding into eating disorders in people that have lipedema. You need to be mindful of that. You don't want to necessarily go crazy with the calories, but there are better strategies than that in working with lipedema. And nutrition is still vital to help prevent the progression, and you really can use nutrition as a tool to improve a lot of the aspects affected by lipedema. For example, you can improve the vascular integrity, you can decrease inflammation, you can improve insulin sensitivity, improve cholesterol if you need to, and it really can still help with weight loss. The primary dietary strategy that has been the most popular over the past few years for lipedema is the ketogenic diet, which is a very low carb, high fat, moderate protein diet. And there are some studies on that as well. The ketogenic diet has been shown to reduce pain in lipedema independent of weight loss. And a more recent, or another 2021 study in addition to that one, has shown that the modified Mediterranean diet can also help reduce the limb size in the legs and the arms and improve other aspects of life, just ability to kind of do your daily living. Intermittent fasting is another strategy that some people have found helpful. You can do that in a few different ways, and including like a daily restricted time eating where you fast for 16 hours of the day and eat for 8, or the 5-2, which is fasting for 2 non-consecutive days of the week and eating regularly for 5. So intermittent fasting has been shown it can help convert white adipose tissue to brown adipose tissue. And lipedema is a condition affecting the white adipose tissue. So it naturally seems like it could be beneficial to see more of that converted to brown adipose tissue, which is also what's considered more thermogenically active. So it releases more calories burned as heat. In general, an anti-inflammatory diet is a good idea, and that can look a little different for different people. In general, a Mediterranean diet is considered a very classic anti-inflammatory diet that works for most people. There's also specific nutrients you can target through nutrition that may help support the vasculature, like proanthocyanidins. Those are compounds found in purple and red and blue fruits and vegetables, and they're great for your vascular health. Selenium is great for your lymphatic health, and you can find that high in Brazil nuts. Citrus bioflavonoids, though they are found in food, it's a little harder to get this through diet alone, but I wanted to include it here. Those have been studied in venous insufficiency, in lymphedema, and shown to reduce bruising and swelling and all that good stuff. So there's a lot you can do with nutrition, but it definitely needs to be personalized. Not everybody can or should do keto or shouldn't do it long term. The modified Mediterranean keto, it may be a good option for some people, where it's less likely to have adverse effects on cholesterol for people who have that problem. So yeah, there's a lot you can do with nutrition. Okay, as far as exercise goes, I think the big picture here is whatever you like to do and are more likely to do consistently is the most important, but there are certain strategies that can be even more beneficial for lipedema and lymphedema. Swimming, walking, using a rebounder, aquacycling, those are some of the key ones that tend to support the lymphatic movement even more. Aquacycling was studied in lipedema specifically, but of course that's a little harder for some people to find, though it is out there. So if you're interested, you might look around. And I would be remiss if I didn't talk about mental health here, because it is a foundation of health, and it is very common for people that have lipedema to have some kind of depression or anxiety or eating disorder, such as binge eating disorder, or at least not the best relationship with food, perhaps, over their lifetime. And of course, dealing with fat bias from their doctors, from the workplace, etc. So I think identifying if this is an issue and finding help for this aspect of care is important. Okay, so I'm going to go into another angle of my approach to treatment, and that is trying to identify and treat the cause. So we've already identified that hormones, inflammation, vascular and lymphatic support are areas that could use some help. I'm going to talk about these individually. So as far as hormones go, I think future treatments will probably more specifically address that estrogen receptor difference that we see in lipedema. And at this time, we don't necessarily have a great way of doing that where we would feel comfortable doing it across the board. Currently, my approach with hormones and lipedema is being very patient-specific. Many people have thyroid conditions or other hormonal conditions like PCOS or endometriosis that can increase inflammation, or it could cause more challenges with weight loss like insulin resistance. So I specifically try to address what each patient needs with that. And another thing I like to do here is talk about endocrine disruptors. So I'm going to talk about this on the next slide in more detail. So endocrine disrupting chemicals are ubiquitous. They are in our environment everywhere. They're in food packaging, plastic bottles, toys, pesticides, skincare, cleaners. The list is pretty much endless. And we know that a lot of them can actually interfere with our hormones or can actually stimulate or adversely impact hormone signaling. And specifically, it can do so by interacting with estrogen receptors, alpha and beta, that we know are impacted in lipedema. And so it's important to me to try to reduce how many the people are exposed to and start identifying them in our lives. A few examples of them are listed there. BPA, which is often replaced with something just as harmful like BPS. Phthalates are very common. So What I like to do is refer people to the Environmental Working Group's website that has some great resources on there, like the Skin Deep app or the Skin Deep website, where you can look at individual products and maybe start making some swaps. And this is something that I talk about with a lot of my patients, and we can actually look at individual products at times and try to prioritize what we might want to swap out there. All right, so we talked about hormones. We also want to try to reduce inflammation. And naturopathic doctors can do this in a lot of different ways, especially with nutrition. You can reduce inflammation there. We talked about that already somewhat with the Mediterranean diet, and ketogenic diet can often reduce inflammation as well. You can also identify somebody's specific food allergies or sensitivities and remove those. And addressing other types of inflammation like that related to metabolic conditions like cardiovascular disease, high cholesterol, prediabetes, and all that kind of stuff. And then there are plenty of nutraceuticals or supplements that are well studied that have a good anti-inflammatory action. And some of these may be better for one person than another for different reasons, but curcumin is the main ingredient in turmeric and has a lot of different anti-inflammatory mechanisms. NAC is an antioxidant that is a precursor to a main detoxification molecule called glutathione, and that one can be great. The SPMs are very interesting. That stands for Specialized Pro-Resolving Mediators, and that can help reduce inflammation through the resolution phase of inflammation, and those are actually just derived from omega-3s. I know that's maybe a lot of detail too fast about those items, but there are lots of different ways we can try to approach inflammation for each individual. All right, so vascular health here. So this slide is a little outdated, but there are a few things I want to talk about on here. The lipedema, as we talked about before, can cause an increase in aortic stiffness. So with that, there are some things that we can do to help improve aortic stiffness. Not everybody needs these things, so just be mindful about, you don't need to take everything that I mentioned if you do have lipedema. I think it really does need to be individualized. But there are some studies on vitamin K2 and how it can help decrease arterial sclerosis and reduce arterial stiffness in postmenopausal women. I think it's not a bad idea to test homocysteine in patients that have lipedema. This is a marker of vascular dysfunction, and there are some genetic influencers as to why this might be elevated in some people. And it's relatively easy to improve this marker. So if it's elevated, which it isn't always elevated in lipedema, but if it is, there are some easy ways to bring it down and reduce some of the risk factors for other issues with their vascular health. Antioxidants can also help with vascular health, and nutrition and exercise can be used to support vascular health in ways that we already talked about. This pathway on the left just has to do with that homocysteine pathway. You can see it kind of in the bottom left of that circle. And the vitamins there, the folate, B6, B12, those are some of the things that actually can help homocysteine levels improve. All right, and addressing lymphatic health. This is an area that most people with lipedema actually end up seeing more, most of their treatments involved in this area, because we already have a lot of therapies available for lymphedema and supporting lymphatic health. So you might have heard of manual lymphatic drainage or complete decongestive therapy in some cases. There are lots of different therapists that can perform these different types of therapies for patients and people who are experts in fitting compression garments. And this is a great resource, especially if you have lymphatic impairment. If you have lipedema without a lot of lymphatic impairment, you may not see as big of a difference with those treatments, including the pneumatic compression device. But it's still important to support your lymphatic system, even if you don't know of any significant lymphedema happening, just because it does appear that over time, people with lipedema can often have their lymphatic pumps actually get overwhelmed by some of that debris that builds up between the cells. And so doing things like dry skin brushing at home, which is just taking like a natural fiber brush, gently moving it from your legs up towards your heart, that can actually be sort of an at-home maintenance sort of thing to help support your lymphatics. And certainly some of the nutrition that we talked about before with selenium, citrus bioflavonoids, and the movement exercise. This also reminds me that I am actually doing a talk on lymphedema and nutrition next month. So keep an eye out for that as well. Whole Health will do emails and social media posts, and I will too, about that. So if you are interested in learning more about nutrition and lymphedema, then tune in for that. Vibrotherapy, this little section on the side here, there are some studies on lipedema with that and how it can drastically improve outcomes when combined with the manual lymphatic drainage. So that can be done in different ways. That it could be mechanical, through water, through massage, but that vibration seems to do part of the trick. Let's see here. All right, and recently a small study was done at the University of Arizona on what's called SAT therapy, or subcutaneous adipose tissue therapy. As I said, this was small, so there were just 6 patients with lipedema enrolled. It was over 4 weeks. They did 12 90-minute sessions of SAT therapy, and they showed a significant reduction in weight and leg volume. By ultrasound, there were fewer of these hyperechoic masses that they had seen prior to beginning the study. And so this is actually an interesting treatment to consider in the future. And I think the biggest thing, so there are some side effects to SAT therapy, including pain and itching and stuff like that. But most of the participants, if not all of them, said that they would recommend it because they did see a substantial change. The problem here is that we would need these things to be available and larger studies to be done. So when larger studies are done, I think they will do more trainings, and people that are already doing things like lymphatic massage would certainly want to train for something like this if it was going to help their patients. So this is something hopefully on the horizon for a treatment in the future. So now I'm going to talk about a few procedural treatments like liposuction and whether these are good options and or if they are not. So the first section here, I'm going to talk about liposuction, cryolipolysis, and bariatric surgery. So starting with liposuction, liposuction can be appropriate for some people. There are a number of studies showing that this can improve quality of life and pain in addition to improvements aesthetically. It doesn't necessarily make it go away completely, but it can cause pretty substantial improvements in the condition. And when followed 8-10 years out of surgery, people continue to have the benefits that they had with the surgery. It doesn't just come back. There are, of course, risks with that, and I know most people have not had a lot of luck with insurance covering it, but maybe that's changing. With cryolipolysis, this is like cool sculpting, for example, as one example of cryolipolysis. I don't think this is a great option for lipedema because in cryolipolysis, you're intentionally damaging the fat cells, which we know is part of the problem with lipedema. We know that's already happening is fat cells are damaged. And you also need to have good functioning lymphatics in order to remove those fat cells out of the area. And we know the lymphatic pumps are already getting overwhelmed. And furthermore, cryolipolysis tends to focus on smaller areas than are affected in lipedema. So to me, it just doesn't seem like a great fit. And bariatric surgery does not work for lipedema. Of course, if you have another issue on top, like lifestyle-induced obesity on top of lipedema, it could help with that part, but it's not going to affect the lipedema to any significant degree. And I added this slide because somebody asked me after a talk one day about cryotherapy, which is different than cryolipolysis. And I thought, well, other people might want to know the answer to this too. So cryotherapy is often used in athletes where you can use it for recovery from an athletic event or from training. And you spend a couple minutes in a very cold chamber as low as negative 166 degrees Fahrenheit. And it's kind of interesting. It's actually been considered for a treatment for metabolic conditions and obesity because it actually can help mimic exercise and some of the benefits you can get from that. And it actually converts white adipose tissue to brown adipose tissue, as we already talked about. So moving away from that white adipose tissue that's affected in lipedema to more thermogenic brown adipose tissue. And it doesn't damage the fat cells the way cryolipolysis does. So I'm not worried about that piece. And there is at least one study in fibromyalgia that showed significant improvement in pain, mood, and quality of life. And so with that overlapping condition, I would have some optimism that maybe it could potentially benefit lipedema as well. But currently we don't have studies on that yet, but that would be an interesting one to see. And maybe we'll be the ones to do it someday. All right, I wanted to include a few other frequently asked questions I have had from a few patients, like are patients with lipedema at an increased risk for COVID-19? So right off the bat, there are no studies that I know of on COVID-19 and lipedema, but there isn't an immunodeficiency with lipedema, and often people actually don't have elevations in the SED rate or CRP, which are the two main inflammatory markers that are tested routinely. And so without that immunodeficiency and without that elevation in SED rate, it's not expected that you would have an increased risk, but many people might have an increased inflammation marker like a SED rate or CRP for other reasons, and those can increase your risk for more severe COVID. And maybe you have other conditions or other obesity or things that might increase your risk that are not lipedema. And another question I get frequently is if lipedema is progressive. A big fear people have is if they gain weight, does that mean it's never coming off? Is the weight they gain there to stay? And they see pictures of maybe later stages of lipedema and wonder if that will inevitably be them. And the answer is no, that is not necessarily going to happen. There's a good chance it won't, especially if you are being proactive, which you probably are if you're listening to this. And I commonly see women in their 70s and 80s that are just now being diagnosed, but they are stage 1 or stage 2. And so I don't think that should be a big fear people have. I do think you should be proactive and do what you can. So you don't have to work extra hard to lose it. But yeah, so and lastly, where can you find more information? A few of the major resources out there include, see if I can get there. Here we go. The Lipedema, oh, sorry about that. The Lipedema Project, Lipedema Foundation, and the Lymphatic Education and Research Network, or LEARN. These are all really good resources for lipedema and, of course, lymphedema as well. And if you, of course, are interested in coming to our office or doing a telehealth visit with me, I'm happy to be another resource for you as well. So if you're interested in that, then you are welcome to call our office at, I didn't include it here, but it's 860-674-0111. I'm at Whole Health Wellness Center in Avon, Connecticut. And again, on the next page, you're going to see a way to sign up to talk to our office. So thank you for joining me tonight, and I hope that you learned something, and have a good rest of your week. Bye.